So without further ado, Tori and Eileen, take it over, please. Thank you so much.
Thank you, Josh. Good morning. We're so pleased with the turnout. I hope everybody's been having a great time here and you've adjusted to the salty air. I love it. I grew up in Marblehead, which is up north of here, but also very salty. So this is a lecture for primary care and other specialties, nurse practitioners who don't see a lot of psoriasis every single day. So Eileen and I are hoping that we can really empower you to find your next psoriasis patient and get them on treatment, talk to them about possible comorbidities, talk to them about their disease, and if needed, send them to a specialist. Thank you for having us. Eileen, want to do your intro?
Sure. Yeah. Good morning. I'm Eileen Cheever. I'm a dermatology PA in Central Massachusetts. I'm at Clearview Dermatology, right outside of the Leominster-Fitchburg area. I've been a derm PA since 2008, since I've been a PA, and my primary focus is family dermatology, so all ages, all stages. And really, as I've continued to evolve in practice, I've focused in two areas: chronic inflammatory disease in dermatology, so psoriasis, atopic dermatitis, a condition called hidradenitis suppurativa. And I've also really shifted to the education portion of this as well, not only in those exam rooms with our patients, but also speaking with colleagues, whether it be in the dermatology setting or folks like yourselves, to really provide that disease state education and that awareness of what these inflammatory diseases are all about from a patient point of view, but also a real holistic point of view. And I'm really happy to be here on behalf of the NPF and look forward to a great session today.
So I'm Victoria Garcia-Albea, but I go by Tori, and I am a nurse practitioner in dermatology since 2006. I also started my career right in dermatology, which is a little unusual for nurse practitioners. I was fortunate enough to do a nurse practitioner training program that I now run at the Lilly Clinic in Burlington, Mass. And I have a subspecialty in pediatrics and hair loss. I also help run our Hansen's disease program, which is leprosy. So if you guys ever encounter leprosy, send them our way. I think my email is available. And I think I met you through speaking, through educational programs. So I also, as I run the training program, obviously have a strong love for for mentoring and teaching, and also just lecturing on all topics. So, afterwards, if you have any derm questions, happy to answer. So we're so fortunate to be here on behalf of the NPF, but also to be sponsored by generous grants from these wonderful companies so that we can provide this education to you all here. These are our accreditations, so you will get CMEs for this presentation. And here you go, more info on the credits. All right. So the outline today is we are going to review the pathophysiology of psoriasis, not too in-depth, not too basic science, enough to understand the key cytokines and molecules that are involved in this disease. We're fortunate to be practicing in this time when we really know a lot about it and we can get very specialized with our treatments. We're going to talk a lot about the different presentations of psoriasis, what it can look like, so differential diagnosis, mimickers. We're going to talk about comorbidities, and then we're going to end with treatment. There is normally a third hour that goes with this presentation, which is available online from our amazing co-worker friend, Veronica Richardson. So please, go online at your convenience to watch that 1 hour presentation. It's case-based. Our presentation today is not case-based. That one is case-based. There's like 6 different cases with difficult conundrums. So if your patient needs surgery, if your patient is pregnant, if your patient has cancer, different scenarios that we come in contact with in daily practice that are a little bit tricky. And the objectives, we are going to talk about the pathophysiology of psoriasis as a chronic immune-mediated inflammatory disease and what that really means. We are hoping that we can improve diagnostic accuracy. We are going to really delve into comorbidities and then talk about strategies for treatment. And I'm going to turn it over to Eileen.
Great. Thanks, Tori.
You're welcome.
Yeah, and that third hour that Tori alluded to, we have a QR code at the end of the presentation that you guys will be able to scan to get access to that third hour. So if you're wondering where it is or how you access it, we'll have a QR code at the end. So let's kick off with just the fundamental basics of what psoriasis is. So psoriasis is a chronic immune-mediated condition, and it primarily has cutaneous manifestations. We know that there is this amped up, inappropriate immune response that causes this large infiltration of inflammation through these mean, nasty proteins called cytokines. And there's a number of different cytokines that feed forward. We talk about feedback loops, but feed forward this propagation of inflammation in our patients. And we know that when they have this feed forward of inflammation, it results in inappropriate production of excessive amounts of skin cells. These keratinocytes are overproliferative, and that leads to the presentation you see here on the screen. As our knowledge about psoriasis has continued to evolve, we know that this condition is more than skin deep. It is multifactorial, and the number one thing that we're looking at in dermatology when we have a psoriasis patient to the office, and Tori will dive more into this later, is psoriatic arthritis. That same feed-forward inflammatory loop that gives a patient psoriasis, like you see here on the screen, that same type of inflammation can infiltrate the joints. And that's what we call psoriatic arthritis. If we have a psoriasis patient walk into our room, they essentially have a 1 in 3 chance of developing psoriatic arthritis subsequently. And a question I get commonly from patients is, well, will I ever get psoriatic arthritis first and then psoriasis? It happens, but it's pretty rare. Typically, I'll have a patient come in referred to me from rheumatology, and they'll say they want to know if I have psoriasis. They're hoping you tell me this little patch here is psoriasis because I have this bizarre arthropathy, this arthritis going on, and they don't know really what it is. And they want you to look at a couple of these rashes to see if it's psoriasis. I'll be honest, that rarely happens. Sometimes it does. Sometimes the patient goes in because their joints are so painful, and then the rheumatologist peeks behind the gown and says, whoa, how long have you had this rash? A lot longer than the joints, but I'm really here for the pain. I don't care about the skin. Okay. But for all intents and purposes, generally we have a plaque psoriasis patient walk into the room. Automatically, we're screening them and asking them about their joints as one of the most prominent comorbidities because of that inflammatory infiltrate, not only affecting the skin, but also infecting the joints. Again, as our knowledge about psoriasis has evolved, we know there are other comorbidities that you guys can be such partners in helping us look for and screen for, and those comorbidities continue to widen. And I find myself leaning on a lot of my primary care colleagues to help me manage these psoriasis patients, because as I mentioned, it is really multifactorial. When I was graduating PA school and I told my colleagues and mentors that I was going to go into dermatology, I mean, come on, how challenging is that? If it's dry, wet it. If it's wet, dry it. And now I can reach out to these colleagues 18 years later and say, I give patients their lives back. We have the ability in dermatology to change patients' lives. We can do this with the drugs that we use in dermatology. We are literally saving patients' lives with the comorbidities of mental illness that are associated with psoriasis, the stigma, the disability, the lack of social and occupational participation. This is no longer a specialty where it's dry, wet it, wet, dry it. We are changing patients' lives in dermatology, and it is just an absolute privilege to be able to be in the specialty and be able to work with patients and give them their lives back, especially when they have psoriasis. So who is that psoriasis patient? Who is that next patient to walk into your door? You know, these statistics are still pretty accurate, maybe a few years behind, but we think 8 million people in the States have it, men and women equally affected. 125 million people around the globe we think have psoriasis, and there is a representation amongst most races with a slightly higher preponderance in the Black community. And we know that there is this bimodal distribution of the ages of patients who get psoriasis. Unfortunately, we see psoriasis perk up in a lot of our patients where life is just starting. Things are just starting to happen. Patients are getting jobs, they're working, they're starting families, they're moving. They're really at the onset of their adult and professional lives. And unfortunately, we see psoriasis come in at that time. Why? We don't necessarily know. I'll allude to a few reasons why in a few moments, but we think that genetics plays a huge, huge role in this. And we also have some pretty good research that stress can be a trigger for psoriasis too. So you're 20 to 30 years old, living the time that we're living, trying to get your feet on the ground, trying to establish a family, find a place to work, etc. And by the way, you have this genetic predisposition for psoriasis, and boom, here you go. So that age 20 to 30, is there a correlation with that stress? And then we see another peak in age 50 to 60, which, again, we see life is pretty established at that point. But a lot of times we're starting to see those patients who have those comorbidities, perhaps pre-existing or perhaps in collaboration with psoriasis. And sometimes, not only always, that can make treatment selection a little bit more challenging or a little bit more difficult. And sometimes we'll lean on our primary care colleagues to give us a handle or a sense on how these patients are in terms of comorbidities we're screening for. So as I mentioned a moment ago, we really do think that genetics are at the heart of what makes a psoriasis patient. But we know that it can be flared by a number of factors. So stress can definitely be a factor. We know that there are certain variants of psoriasis that can be brought forth initially by infections like things like strep. And then a good proportion of those patients will go on to develop that classic generalized plaque psoriasis. Or we know that patients have had psoriasis for years and perhaps they're under control and then they get an infection, they get the flu, they get COVID, and they call and say, look, my psoriasis was doing great, but now things are flared up. We know the impact on the immune system if patients have an illness can sometimes flare up their psoriasis. Medications inducing psoriasis, it can happen. It's important to be on your radar, but typically not something, though patients will ask all the time. As I'm sure you have in your practices, patients always want to know why. They want to know why they have something and if it's something they can do to change it or undo it. So this may be a question that comes up a bit. And of course, skin trauma, we know there are phenomena in psoriasis where if patients are picking at their psoriasis lesions or scratching at their psoriasis lesions, that can make more psoriasis. So there's a lot of these different concepts, but we really do think that the background of psoriasis is really a genetic predisposition to eventually developing psoriasis. So these next few slides will dive into the pathogenesis of psoriasis. I'll keep it high point, impactful, and I think clinically relevant. So we're all obviously familiar with our immune system, and I hope most of us are familiar with the fact that the immune system really runs on two processes: the innate portion of our immune system and the adaptive portion of our immune system. And I like to think of a castle metaphor or analogy when I'm thinking about what is innate and what is adaptive. So think of a castle, and there's this wall around the castle or this moat around the castle. And that wall around the castle is your innate immune system. It's present, it's there, it's the first line of defense. It isn't specific, but it's just this broad protector. And it really doesn't have any memory or learning. It's just there, it's broad, and it protects that castle. Your adaptive immune system are the knights that are in that castle that when the immune system comes under attack, they might be a little slower to respond, but they are specialized, they are trained, they are targeted, and they remember that enemy next time. So that's the difference between your innate and your adaptive immune system. And unfortunately, for our psoriasis patients, they get a double whammy. They get a little bit of innate and they get a little bit of adaptive when it comes to the pathophysiology of psoriasis. So essentially what happens is there's some type of signal, whether it's trauma, it's genetic, that signals our dendritic cells to then get on the upkeep. And when those dendritic cells are stimulated, they actually start to encourage the production of IL-23. IL-23 is one of those mean, nasty proteins called cytokines. And that IL-23 then starts off what we call the IL-23 or the 2317 pathway. We think the main axis or the main pathway driver of psoriasis. And as IL-23 is produced, It then causes the TH cells to become naive to then start producing something called IL-17 and also IL-22. And then we start to see the propagation or the proliferation of that inflammation. Those keratinocytes start to propagate, they start to thicken, and then next thing you know, you start to see that psoriasis plaque. So those dendritic cells are really one of the first things that sets off that inflammatory cascade, tells IL-23 to start being produced, then knocks on the door of those T cells, which then produces IL-17. And then we see that hyperproliferation of keratinocytes as well as that overall inflammation. And ironically, those keratinocytes and those plaques also participate in that feed-forward loop because those keratinocytes also enforce inflammation and can also attract and stimulate more cytokines. So more plaques, more inflammation, more inflammation, more plaques, more plaques, more inflammation. And it's this continual feed-forward loop. Tori, any comments about that at all in terms of what we see in terms of that pathophysiology?
I'm going to get into it in the comorbidities, but the plaques that we see on the skin are really a window into the plaques that we know are there in the arteries. And when we first started in dermatology, I was 2006.
Shortly after, yeah.
We honestly thought that we were like so amazing because we were screening for psoriatic arthritis. It was brand new that this was, related, even though it's in the name, right? But now we are really being tasked with screening for so much more, which is why we're trying to, recruit you guys as our allies to think of our psoriasis patient, not lucky, but with almost like a fortune teller. You can see they have psoriasis, so we can predict the higher rates of, psoriatic arthritis, all the stuff I'm going to get into, all the bad things that are related to inflammation. So.
Yeah, so a lot of this pathogenesis that we're seeing in psoriasis, as Tori alluded to, is really part of that pro-inflammatory state, that multifactorial inflammatory state that these psoriasis patients are in. So you'll see a lot of commonalities in Tori's next section. So as I alluded to, and what we're going to come back to, and you're just going to notice, this slide is going to be a touch point really for the remainder of this morning's presentation. This IL-23, IL-17 axis or pathway, we think is really the key driver of plaque psoriasis in our patients, and to a great extent, psoriatic arthritis. A lot of the drugs that we are seeing, that we are using with high levels of efficacy and thankfully high levels of safety are targeting this pathway because we think this pathway is really key to modulating that cell differentiation and the activation of those specialized cells. And Tori will get into those comorbidities that we see often associated with the cytokines we identified in this pathway. So now that we have an understanding of who these psoriasis patients are, where their psoriasis comes from a pathophysiologic point of view, I want to take you through a number of presentations of psoriasis. This next section, I hope, really makes you put your thinking cap on when we talk about differential diagnosis. As a lot of patients eventually make their way to a specialist, they'll come in and they come in with their little shopping bag of all these different creams that maybe they bought online or they were given prior to seeing us, and we'll go through them and reconcile and take a look at them. And it's always very interesting to see that either the patients or somebody they saw says, oh, where that psoriasis is located or what it looks like, it's got to be fungal, it's got to be yeast, it's got to be XYZ. So I hope the next series of photographs will really broaden your differential diagnosis when you see these patients come in. And I like these next sets of photographs because they do represent various skin tones as well. And we've really seen a beautiful shift in all of the inflammatory dermatoses, but especially in psoriasis, to make sure that we're seeing psoriasis presentation in a variety of skin colors, seeing what psoriasis looks like on skin of color, and being able to appropriately recognize that and provide patients with resources that say, hey, this patient looks like you. This is what psoriasis looks like in patients with skin of color. Because for too long, we have references that are all just Caucasian skin. And everybody says, well, that's not me. Why would you show me a brochure for a medication that study participant doesn't look like me? Completely valid. And finally, a lot of these companies have heard that it's time to represent the patients who are in those clinical trials, who are in our offices, and it's slow. It is very slow. It's slower than we would all like, but it is happening. So hopefully these photographs do broaden your differential horizon. So just to kick everything off, this is typically what a typical easy, field go through the uprights type of psoriasis looks like. We see that plaque that has that thick silvery scale. We can see that it can be thicker certainly during types of presentations. And we can see that it has that sometimes confluent look where it's kind of out there, but then it's spreading into little other avenues. So some people see that and they think, oh boy, that's got to be something advancing like a tinea. But that can just be one confluent patch of psoriasis. So a lot of different presentations here. You can see on that lower left where there's a bunch of tiny ones. I think if we were to expand that picture, that's probably a patient that has something called guttate or guttate psoriasis, which guttate means of the raindrop or the teardrop. So these patients are covered in like 250 to 500 tiny little microplaques of psoriasis. And then we can see that thick plaque. What's that term that we always use?
Ostraceous.
Yes, ostraceous.
It's appropriate for here.
Super thick.
It looks like an oyster shell.
Looks like an oyster shell, exactly. Okay, so these are two actual patients of our colleague, Veronica, the one that will be doing that third hour of enduring content. These are two of her patients who ended up being diagnosed with psoriasis. So if you look at the patient with Caucasian skin on your left, you look at that and you say, is that a psoriasis case? It doesn't necessarily affect the elbow or the actual cap of the knee. It's going down that side of the shin. It's actually creeping up the foot. There's really no way that this can be psoriasis. And there's also all these other tiny little dots. Is this something vasculitic in nature, like a vasculitis? So this one ended up being psoriasis, but definitely made you put your thinking cap on.
And don't forget, like you mentioned, patients are putting stuff on. So this might be somewhat treated because maybe they have hydrocortisone over the counter, which is helping with the scale. Obviously, it's not clearing it up. Or, we see international patients. They come in with their tubes in Greek, and I'm like, what is this? So, just make sure you're asking what they're doing to it. Or some of our patients are going tanning. I think less so than when we first started, but some of them will have realized that the sun helps. And so they'll be going tanning, and it can look like less scaly and be harder to diagnose.
Yeah, and you'll say, where is that thick silvery scale that has an aluminum foil type of color to it? It's absent in that patient, and there, as Tori alluded to, can be a number of reasons why. Our other patient here, our African-American patient, you would look at this and be like, don't touch this, it's tinea, it's tinea corporis, run for the hills. Like, do you volunteer at a veterinary center? Like, do you have pets? Like, where have you been? Like, and turns out this is psoriasis. This is an actual psoriatic presentation in a patient with skin of color. And we know that erythema in darker skin tones presents differently, often erythema that you would see on a lighter Fitzpatrick skin type. So a Fitzpatrick skin type is how easily the skin tans. So for instance, I'm a Fitzpatrick 2, and this patient would be a Fitzpatrick 6 because of their inability or ability to tan. So if you look at redness on skin tone like mine, you're going to see redness. If you see skin tone in a darker Fitzpatrick skin type, it's going to look more violaceous, etc. And you can see the scale on this. You can see there's a number of them. They're clustered closely. You may even, if you were to zoom in close, look at the edges and see a scaly border. Totally get it. Reasonable to have in your diagnostics that this could be tinea, but this actually ended up being a presentation of plaque psoriasis. And the tough thing about these inflammatory dermatoses on skin of color is pigmentation alteration. So we really do need to identify psoriasis, atopic derm, these inflammatory dermatoses as soon as possible, because oftentimes the patients will report to us the pigmentation is more alarming and concerning to them than often the primary rash that we end up getting cleared up. Patients will come in and say, I'm no better. And we have them in a gown and we look and their psoriasis is gone, but they have severe alterations in their pigmentation. So timely diagnosis is really key. Anything to add?
Just that with the creams, you're going to be treating what keeps coming out. So you really want to go more upstream and prevent the plaques from coming out, which is what we now have the opportunity to do with all these, advanced treatments.
And then also with this type of presentation of psoriasis, there's a lot of it. So then They have to go to every single one of those patches with a steroid cream and try to treat those twice a day. There'll be treatment burnout and compliance issues for sure, but then we also have to make sure up front, if you do decide to treat this patient topically, let the patient know that this condition will likely leave pigmentary alteration. And there is always a possibility that a topical steroid can do that as well, especially in our darker skin tone patients. So if you're going to treat a psoriasis patient or you're going to monitor inflammatory dermatosis like this, it would be a great idea to do baseline photographs. So if this patient comes back and says, my skin's clear, but this cream, it bleached my skin. Common presumption, common thing we have to caution about. But you need to make sure that you're photographing, you're documenting, because this condition can leave pigmentation alteration. You should document that in your note. And then also the risks of the steroid doing the same. But we can see that as sometimes a treatment pitfall with darker skin tones as well. Again, some really nice representation across all skin tones in terms of what plaque psoriasis looks like. If you look at the one that's closest to me, again, has a little bit of a wormy, advancing border. First thing you would probably think is this is probably a tinea, a ringworm, a tinea corporis. There's another benign, non-inflammatory, benign, non-infectious condition called granuloma annulare, where they get these kind of rashes that cuff and kind of are more prominent at the edge and a little bit more clear in the center. But that's a psoriasis patient. Same thing, this patient on that forearm area. We can see that pigmentation at the end, at the edges, that thickness through the center, and then that representation in the lower back.
And you can see the PIH, the hyperpigmentation on that one on the right.
We can already see that pigmentation alteration happening, and we think that the pro-inflammatory state that the skin is in really propagates the activity of those melanocytes. So again, a typical case where a patient may come into you. I think that this looks a little bit more hallmark to me for psoriasis, but tinea capitis being on the diagnostic differential. I get it, totally. But again, this is a patient where history is important, asking about joints, asking if they have rashes anywhere else, and then getting this patient treated and treated appropriately as soon as possible. Because yes, he comes back into your office 4 weeks later and you think, home run, nailed it, it's psoriasis. But now he wants to keep his hair short and he has this pigmentation. His friends, his family, his colleagues are asking about these dark marks. And that is a very, very long road and a very, very long conversation in terms of what we can do to improve that pigmentation. We're not talking about days or weeks. We're possibly talking about a couple of years. So it's double-sided. Keep that psoriasis away. We know psoriasis can be relapsing and remitting if you're just treating topically, but then also trying to work on the pigmentation at the same time. This can be a very challenging case to treat.
Yeah.
So talking a little bit more about scalp, it's a very common area for us to see psoriasis. And in our field, they call the scalp a special site for psoriasis. And when I go out and I give talks, I say, there's nothing special about treating psoriasis on the scalp. It is tough, it is difficult, it's annoying, and I hate it. Primarily because I'm female, I have fine, greasy, oily hair. I can't imagine being a patient, a female, a male who has thicker, longer hair, where I'm trying to treat topically or with one of these terribly compounded shampoos to try to treat this condition. And unfortunately, we know about half of our patients, if they have psoriasis, unfortunately, they're going to have it in the scalp. And what we have topically for preparations are messy, they're gross, they're inconvenient, they smell terrible. They're not always necessarily convenient for color-treated hair, and also for folks who have certain hair styling rituals. It's our job to be culturally competent and conscious of how different people style their hair. If you go in that room and say, you have plaque psoriasis, here's a shampoo, wash 3 to 4 times a week, and that patient culturally maybe shampoos their hair twice a month, as far as I'm concerned, you've lost that patient. That patient right then and there knows you have no idea how to treat them or treat people like them. And topicals can be really hard for that as well. Diagnosing this, we also want to take a look at the scalp and automatically start thinking about joints. If we see scalp psoriasis, radar should be up for psoriatic arthritis. There's a correlation of if you have psoriasis on the scalp, there's a higher incidence of developing psoriatic arthritis. So this is one of those special sites. that we want to have on our radar to look for joints. Another presentation of psoriasis, inverse or intertriginous psoriasis, psoriasis that occurs between a skin fold. So we can see it sometimes with an overhanging pannus. We can see it in the inframammary area, the gluteal cleft, and sometimes along the underarms, but also behind the ear is considered technically intertriginous. And this is often a diagnostic conundrum because our psoriasis patients, as Tori will allude to, often have the comorbidity of obesity. So a lot of times they're dealing with hanging skin, moisture, etc. Completely reasonable. I get it. When this patient comes in, you look at this, say it's yeast, it's candida, it's fungal, etc. And a lot of our patients come in asking about that. But we can see a psoriasis presentation present inversely. And obviously it goes without saying, any type of intertriginous rash can present really issues with interpersonal relationships. Patients feel a sense of shame regarding their hygiene. If they have it in an area close to the genitals, which we'll allude to in a moment, can impact sexual relationships and that type of interpersonability. And this can be diagnostically a challenge, so don't be afraid to get your dermatology colleagues involved. Treatment for this area can be tough because a lot of times this condition is stubborn and patients are uncomfortable and you want to get them better right away. And sure, a topical steroid may be the quickest route to get them improved, but a topical steroid in a skin crease or an intertriginous area presents some issues regarding thinning of the skin, discoloration of the skin. If we occlude a steroid under a skin crease, you can get atrophy, thinning, you can give patients stretch marks or striae. So if you decide to, and you're confident this is an inverse psoriasis patient, this is another opportunity to make sure you're counseling your patients on exactly what you do and do not want them to do for what length of time, and to make sure that you're documenting that you talk to them that despite this being the treatment for them, there's always a risk of thinning, discoloration, striae when you're using it. But I think here in 2025, with some of the nice newer products we have on the market, whether you decide to treat this topically or systemically, we can treat this now in 2025 with pretty low risk.
Yes. And just that if you're not sure what this is, obviously you and I always do skin checks. It may not be something that's normally part of your routine examining this type of patient, but look in the other areas that are classic for psoriasis. Some of them we've gone over: scalp, elbows, knees, look around the ears, check the fingernails, because you're looking for clues that it is psoriasis rather than intertrigo.
And though we're all busy, and sometimes there can be certain things that fall out of our workday, you could scrape this too. There are a zillion YouTube videos on how to do a potassium hydroxide stain, a KOH. It's an essential tool in our dermatology toolbox, where you scrape a little bit of this, put it under a microscope slide, put a little bit of potassium hydroxide, throw it under a microscope, go see another patient, and then you go and you look for hyphae.
You just need a microscope.
Really, really easy. It's cheap, it's quick. If you want to speed up the process, despite my occupational medicine, I have a little lighter that I heat under the slide to kind of try to move things along. And there are a million YouTubes, and it's cheap. If you have a microscope, all you need is some slides, potassium hydroxide, any medical supply company. And you could scrape this, and you could find out in your office if this is fungal, if this is tinea, if this is yeast. And if you're not seeing those yeast or those buds, then again, a psoriasis presentation should be on your radar. A couple more pictures. We talked about obviously where it can be, that gluteal cleft, that pannus area, axillary, and then it looks like around that umbilical area too, a common area that can be challenging.
I've biopsied this before to make sure. I had a child who was like 12 or whatever, where psoriasis isn't as common, and he just had it in the armpits, and I was like, this is so weird. It looked just like the armpit one, and it was psoriasis. So, don't feel bad if you're not sure. And also, sometimes I'm not sure, and I say, okay, we have two options. We can do topical anti-yeast, we can do steroid. The steroid could make it worse if it's yeast. Do you want to take the risk, or do you want to just, do the topical, nystatin first? And we make a joint decision.
I've had a couple of patients who are adventurous and wild enough, and I'm like, I'll give you a nice statin for the left armpit, and I'll give you a steroid for the right. Let me know how you're doing in like 7 to 10 days.
Good option.
Our patients they're tough. You guys, God, you're in primary care. Like, bless you.
I
You
know.
know, you guys are just angels in my mind. But like, patients are like, want to be clear yesterday. So I find as practice has evolved, patients are just less willing to have fun. So that's okay. All right. So gut tape. I talked to you about this earlier. Gut tape are these tiny little 5 to 10 millimeter, tiny little mini psoriasis plaques. A lot of these patients will come in and say, oh, I had strep throat. Mm-hmm. Urgent care gave me amoxicillin. I'm allergic to it. Look at me. And you open up their gown, you're like, oh, thank God. Okay, I'm not dealing with something that I have to get them to an ER because it's Stevens-Johnson syndrome or something, great. Phew, you've made my day. Gut tape psoriasis, because what happens is these patients will develop strep, or some of the case studies report mono, and then they'll go to the doctor and they'll get amoxicillin or a penicillin. And then next thing you know, this blooms as a result. And the patients think, and sometimes clinicians think, this is a reaction to the antibiotic they were given. But we actually know this is an immune response to a little enzyme that the strep leaves behind with the infection. And some people's immune systems, as I alluded to when I opened the talk this morning, are really, really sensitive to that little enzyme. And the immune system then blooms in this specific phenotype of psoriasis. The good news is the majority of this stuff goes away in about 6 to 12 months. Some of our offices have light boxes where we can get our patients into light boxes, and this responds really, really, really well to lights in about 6 to 12 months. You can understand from a treatment point of view, this presents a topical challenge. How are you going to get steroids over 250 little 5 to 10 millimeter psoriasis plaques? It's just not going to happen. So phototherapy, getting these patients into the sun, though not my preference, phototherapy is really, really great for this. And then making sure if these are patients that are strep carriers or strep people, getting them to the appropriate resources to determine if some other action has to be taken regarding the fact that they are continually coming out with strep. And look, there are some cases of this that will go on to, let's say it's quiet, it goes away. These patients will go on to develop generalized plaque psoriasis. I think it's about 30 to 50% statistically. And I do have some gut tape patients that have been very stubborn, and I can say this because it's not a promotional talk, that I've put on some of these systemic agents we're going to talk about later just to try to clear this. This is not something you want to give prednisone to. No steroids, and we'll talk about that later. This is one of those things that you throw prednisone at something like this, you can actually put them into the throes of a very severe emergent psoriasis presentation that we actually have to arrange for patients to have infusions to get them off that dermatologic emergency. So when in doubt, call us, let us know, have this on your radar.
But it can really mimic PR, pityriasis rosea, because of that prior history of strep or sore throat.
Totally.
And syphilis is on your differential too. So never harmful to do an RPR.
Yep, you got it. No, absolutely. So keep that in your differential. So I alluded to, we're very fortunate in dermatology. We don't really deal with too many emergencies. We have a lot of needy patients. We don't deal with many emergencies. It's an emergency to them. It's not an emergency to me at 9:30 at night on a Saturday that you need your tretinoin refilled. But that's an emergency. This is an emergency. Like, this is just a weekend wrecker. You see this at Friday at 2:45. You're like, what's been going on? So erythrodermic psoriasis is when these patients are completely covered, 70 to 90% body surface area, and they are just themselves. They are one big plaque. They are one big plaque. And we know with the skin being the biggest organ in the body, it is a huge thermoregulator. It regulates moisture, et cetera. And when these patients start to go erythrodermic, they start losing water, their temperature thermoregulation starts to go wacky, and next thing you know, these patients are in shock. So this is a dermatologic emergency. We can see it in a variety of different presentations. You want to kind of touch upon that at all?
Yeah, so it's not just psoriasis. So erythroderma is it's like a descriptor. It's not necessarily a diagnosis because it can be caused by any pre-existing or new inflammatory skin rash. So it can be an eczema that goes crazy, psoriasis, obviously. There's an advanced type of CTCL called Sézary syndrome. There's a rare thing called PRP, pityriasis rubra pilaris, drug reactions. So it's not just psoriasis where this can happen. It's a descriptor, erythro, red, dermic, derm, so just red skin all over. They're also in a hypermetabolic state because it takes a lot of energy to have this much redness and inflammation in your skin. So their levels are all off, and so it really is an emergency. They're usually febrile. I think you said that.
Yeah, and we can see oftentimes patients on steroids for psoriasis can sometimes throw these patients into an erythrodermic state. There's also another condition called pustular psoriasis. We can see pustular psoriasis. Again, it can be a little bit of a diagnostic quandary. When you see pustular psoriasis, you're thinking, well, these are pustules, so they have to be either bacterial or they have to be fungal or yeast, et cetera. And they're on fungally, yeasty type of areas. Sometimes you can see it on the plantar surface, and then you can see it on the palmar area. And it's another one of those things like, oh, don't touch me type of thing. Or you can see generalized pustular psoriasis, GPP, which again is another one, thankfully, of our few clinical emergencies we see in dermatology. But we can see this with steroids. We can see this brought on by steroids and then the patient's getting off them. There are different medications that can cause it. And again, one of our emergencies where this is something that actually traditionally now, prior we were using a lot of these traditional therapies, and now we have an FDA-approved medication that works on IL-36, which we think is the cytokine that brings this pustular psoriasis forward. It's something called Spavigo, and we can send them to an infusion center, or if you infuse in your office, you can actually infuse them. But again, just something that we want to keep on your radar. If anything, diagnostically, but also therapeutically. Like when in doubt, just avoid that prednisone.
Yes.
So we talked about that, IL-36, fever, chills, that metabolic state, which I think is a great point. We can see this occur de novo, or they can have a history of plaque psoriasis and they ran out of their medicine, so they go to an urgent care in Hawaii and they're given some prednisone because they don't know their history. And then next thing you know, they're calling you from Oahu saying, I'm covered in pustular bumps. What do you want me to do? You're in Hawaii, I'm jealous. Palmar plantar. So let's kind of put the pustular thing away, but use this opportunity to go to palmar plantar psoriasis. Another special site. Not at all. I hate treating palmar plantar psoriasis. It is so difficult. These patients are often in so much pain. The hand area, the foot area. I had a patient who had plantar psoriasis so badly that she ripped up all the carpets in her home because every time she would walk across, there's not too much breakfast being eaten, she'd walk across her carpet, those little fissures would snag on the thread of her carpet and pull her skin open. So she, as a way to treat her psoriasis, removed all the carpets in her home and put little linoleum and hardwood down because she was in so much pain. A very huge source of disability can be a diagnostic quandary as well. You may see this and think it's fungal. You see that kind of edge or border in that center lower picture. And then you look at the palms, and that can be also even a diagnostic challenge for us. So these patients come in, and let's just take the palms for an example. We are immediately, I don't want to speak for you, but looking for a patch on the elbow, looking in the knee, looking in the ear, the scalp, something to tip us off that this is psoriatic in nature, perhaps putting something infectious aside. Because unfortunately, some variations of hand eczema or contact dermatitis, our beauticians, our patients who do wet work, I've had eczematous patients look pretty much just like that top left-hand photograph. And then what do? We don't do it much. I don't know about you. If you biopsy that hand, what do you get? Psoriasiform eczematous dermatitis. Clinical correlation provided. Garbage in, garbage out. That's what we call it. Garbage in, garbage out. They're going to give you a report that says, it looks a little bit like eczema. It looks a little bit of psoriasis. You figure out what to do. What about you?
No, it's exactly true. And the problem is eczema and psoriasis are like a seesaw. And so one is activating a certain part of the immune system and sort of reducing the other. So let's say you have psoriasis, this side is activated and the eczema side is down. So it's really rare to have both conditions. But if you have eczema, this side is tipped up and the psoriasis side is down. If you choose that it's eczema and you suppress that part, you're going to make the psoriasis go crazy. And the other way is true as well. And I actually did that to somebody because I did the biopsy. It showed eczematous dermatitis with neutrophils, but there weren't that many. And so I put them on a medicine for eczema called dupilumab, and then they got generalized pustular psoriasis. Yeah. And so I knew what it was, but I felt horrible because then we had to switch medicine, and it took a bit of more time to get her under control. So obviously you want to prevent that. There are some overlapping medicines which we can get into, sort of like the older systemics, phototherapy, but it's really tricky.
This can be very, very tricky. And the pressure is on too. Again, another reason why these aren't special sites at all. I mean, they're difficult to diagnose. And then the patients are in so much pain. Like they're literally like, here's my disability paperwork. Yeah. Like, I mean, it's a very, very high stress visit typically. Emotions are running high. You really try to meet patients where they're at. That's where, at least in my office, we're very fortunate to have samples of these $1,000 medications where if I see this, like I'm going into the back fridge and I'm, nailing these patients with medications to try to get them off the bridge. And then again, same thing, topically treating these sites. I'll touch upon that for a moment. A cream, a goop, anything on the hands. I'll be honest, I had an issue this week with my family where my 3.5-year-old daughter, I needed to do some Aquaphor on her hand. She got a burn. And her hand is covered in Aquaphor. I'm massaging it twice a day. I mean, this stuff is gross. It's disgusting. She's like, yeah, mommy, like a 3.5-year-old does. I can't imagine having something like this and then having to have something like an ointment or a cream on your hands twice a day, like forever, trying to give it the time it needs to work and shake people's hands and drive and do any type of thing around the house. This stuff is everywhere. So, short term in little areas, fine. But if this is a palmar plantar psoriasis patient, I'm generally already thinking about what can I do to get this patient off the ledge the quickest. I'm generally not doing much topicals. I don't know about you.
No, I mean, you feel obliged to give them some, but it's completely unpractical.
Yep. Nail psoriasis, another thing on your differential diagnosis. Everybody thinks they have nail fungus. Everybody thinks they have nail fungus. So we have the ability to find that out for your patients. We can do a clipping, we can do a scraping, we can do a PCR, where we can send these little samples, etc. And a lot of times these patients will come in with nails like this, and they'll say, I've tried all these fungus preparations. I've done Vicks. I've been given prescriptions. Nothing's working, and I'm covered in nail fungus. And then you start looking at the actual presentation of the nail, and you start to see these pits. You start to see some of these oil spots that we can see represented on the photographs. And you say, hey, I don't think this is nail psoriasis at all. Well, prove it. Okay, then I do a scraping, and I call them in 2 weeks and say, it's not a fungus. But then I'm starting to look in their scalp. I'm starting to look at their elbows, their knees. And there is a huge correlation with nail psoriasis and psoriatic arthritis. So again, if we see a nail psoriasis patient, right away, I'm already thinking and asking about their joints. Because what's interesting is the actual fingernail itself, the origins of the fingernail comes from that last distal joint space. That is the origin of a fingernail. It comes from that distal joint space. So if we're seeing nail psoriasis, knowing the area of origin of a fingernail, which is a joint space, it would make sense that there's a high correlation between nail psoriasis and joint involvement. This can be a diagnostic challenge, of course. It can also be a treatment challenge because there really aren't FDA-approved treatments for nail psoriasis. There are a lot of things you can do topically, etc. But I'll be honest, I am looking for any type of other psoriasis plaque so I can say they have psoriasis and then try to get their nails cleared up. Because this can be a big, big stigma for everybody, but certainly women, right, who they want to get their nails done. Nails is a huge presentation of their style. It's a culturally common thing to want to have really nice looking nails. And folks feel weird or uncomfortable going to salons, or they're just very ashamed of the nails. So again, trying to be as appropriate and aggressive as possible, especially if nail psoriasis is impacting them socially, but really trying to nail that diagnosis. And it's not always easy.
No, it's not. And they can be painful also.
Yeah, very much so. Psoriasis of the ear, just don't forget that it can be there. We don't have otoscopes, so I have patients come in like, I'm sticking like a hammer down my ear to scratch. What's going on in there? I'm like, I don't know. I do derm. I don't have an otoscope. Like, I had one because I have a 3.5-year-old and she needed tubes. So I did find it and I plugged it into the wall. And but I don't have it in the office. But a lot of these patients will say it's itchy and scaly. So just do your best to look around that ear area. If you see some of those flakes and things like that, let us know. Topical steroids are very common. And most of our patients are usually pretty happy. If you're looking in the ear and around the ear, look behind the fold, look up into that scalp area. Again, can just be a burden in terms of how it feels for patients. Sorry if I blinded you there with the pointer. That. Genital psoriasis, keep it in your differential when you're seeing patients with groin rashes. I'll have patients come in and I see the classic psoriasis on their scalp, elbow, and knees, and they're in a gown all my patients get into a gown and I'll say, hey, do you have any rashes in your groin that you want to talk to me about? Well, I have fungus. I have a cream for that. I have a powder, so I don't need to show you. Oh, how's that treatment work? Well, it doesn't really work, but like it's just there, and I have this powder. And would it be okay with my assistant here if I take a look? And next thing you know, it's genital psoriasis. And perhaps the antifungal or that powder they're using isn't working because it's not of a fungal or yeast origin. And we know that about 65% of our plaque psoriasis patients will have genital psoriasis at some point in their life. So genital psoriasis, as we alluded to with inframammary and intertriginous, can present a lot of interpersonal challenges if you have it in that area. There can be stigma, especially in people who are, sexually active and want to have those close interpersonal relationships. And we do have drugs that have actual label approvals that specifically call out genitals, but we're also pretty aggressive with treating this, especially if there's that high quality of life impact. And again, a treatment challenge, because first, what is it? You could scrape this, and if there isn't any hyphae, there's no buds, great. And now you have to choose a treatment for this. If you want to start topically, that's reasonable, but sometimes the groin and the genitals require a lot of firepower. These patients are uncomfortable. They want to be clear quickly. Look, a steroid does that. I'm not going to stand up here and tell you it doesn't, but you need to have really, really, really good documented guardrails about which one you choose, how long to use it. They don't give it to great Aunt Sally, who then puts it on their face, like a genital cream on their face. Ew. I give Aquaphor out to patients after I do biopsies, and we give little free tubes of Aquaphor. The patient love it. And some of these patients are just so sweet, right? I'm going off into a tangent. I'll say, hey, I have a free tube of Aquaphor. No, don't worry. I use Aquaphor on my baby's diaper area. I have Aquaphor at home. Like, you want diaper Aquaphor in a biopsy site I just put on your face? Like, here, please take the Aquaphor, so.
Even with us, we give out Vaseline, but they're like, oh, I have it. I'm like, how old is that tub?
Yeah, and like, who's been putting their hands in the air and all of that? So you just have to be really, really careful with what you choose to treat this. Know what you're treating, because if for some reason this is fungal and you put a steroid on it, you make it grow and infiltrate. But if this is psoriasis, there are pros and cons and pitfalls and perils about using a high potency steroid in order to clear this. I grazed over it a moment ago, but there's a really great podcast that the NPF puts out. It's called Sound Bites. Really cool. And it has just these really quick hitters about psoriasis, and they're for everybody. Patients could even listen to them, but it really is clinician focused about how do you go about asking those genital psoriasis conversations? How does psoriasis look in skin of color? NPF has a really, really great set of these sound bites that can be really helpful. Okay, so I'll wrap it up and I'm going to hand it off to Tori to take us through comorbidities. So hopefully this last section has really educated you on the immune-mediated drivers of psoriasis and knowing where that psoriasis comes from, this complex inflammatory pathway that is cytokine-driven. And remember, it's a feed-forward loop. It just feeds forward into this inflammation. Really helps drive the idea of where this comes from, and then it leads into how we're going to treat it. And don't forget the various presentations of psoriasis, different patients, different skin tones, different ways that it looks, how it can present, and things to just have on your radar when those patients come through. And now Tori's going to take us through some of the comorbidities that are associated with psoriasis and how you can help us and continue to be an amazing ally in screening these patients.
Excellent. All right. So as I said before, it's associated with all the bad things. So I said a little bit about this earlier, but one person I knew a while ago in derm, she said it's like a window into the internal inflammation that's going on. So this is a busy slide, but you can see in the center the tree. So the tree represents the skin involvement, the psoriasis on the outside. But don't forget that the roots are even bigger, right? So there are so many more comorbidities, inflammation happening systemically that we need to really be aware of and remember. So, the outside is just part of it, and we're going to go into that in a lot more depth. So here are all the comorbidities that we currently know about, and there are probably more, but anything inflammatory is going to have a higher risk with patients with psoriasis, and I'm going to go through most of these in each separate slide. So first of all, we know that we don't screen our patients sufficiently for these comorbidities. So this slide is talking about hypertension, And as I mentioned earlier, when we first started in dermatology, we thought we were so cool asking about joints. And of course, we need to continue doing that because psoriatic arthritis, I'm going to spend a lot of time on, is a progressive type of inflammatory and destructive arthritis. But I think that we're putting on our primary care hats a little bit more because sometimes our patients don't get seen that often. As we all know, we have a shortage, right? It's really hard to get in anywhere. And if we can help to screen our patients and do labs or blood pressures on our patients, we can accelerate getting them on treatment. So in the blue bar, it's how often patients are underscreened. So they're still underscreened for hypertension, but all the orange bars are our psoriasis patients. So overall, there's an increase of all psoriasis patients combined who are not being screened adequately for hypertension. And then mild, it's less. Moderate, it's higher, and severe psoriasis, it's even worse. And less than 50% of dermatologists report screening for hypertension, dyslipidemia, and diabetes. So I think we, on our side, we are hopefully spreading the word that we need to really be doing blood pressures and other screenings on all of our patients, even our mild psoriasis patients. It's pretty easy to do, so I think we just need to keep it in mind. Veronica has a section in her webinar, or whatever you want to call it, the enduring content, where she talks about what to do if your patient has psoriasis and obesity. So I'm not going to spend too much time on this, and Eileen already mentioned it, but our patients with psoriasis do tend to have higher BMIs. And the main takeaway from this slide is that with every 1 unit increase in BMI, there's a 5% increase in risk of having psoriasis. So as weight goes up, the chances of having psoriasis also go up. So they're related. And then metabolic syndrome, so triglycerides and obesity, the risk of having abnormal triglycerides, elevated triglycerides, and obesity increase with disease severity. So we kind of talked about this a little bit, and we'll talk about it more, but we generally classify psoriasis by mild, moderate, or severe disease based on BSA. We've talked about the special sites, so those you don't have to meet BSA criteria, but one BSA, one body surface area percent, is 1 palm of the patient. So if you have a kid, you don't use your palm, you use the kid's palm. But if you have less than 3 palms of psoriasis, if you imagine it all together, because if you have a few small ones, you have to use your imagination and coalesce them all together into how many palms it would be. But generally, less than 3% BSA we consider mild, 3 to 10% is moderate, and more than 10% is severe. And that helps us think about what medicines our patients would be appropriate for. This slide is crazy to me. If you look at the right, the clinical significance, 5 years of life lost. So this is talking about cardiometabolic disease in patients with more severe psoriasis. If you control for everything, age, weight, smoking history, everything else, and you just separate out psoriasis versus no psoriasis, our psoriasis patients die 5 years sooner. That's crazy. So we now really know how much that inflammation impacts their lifelong expectancy. You can see in the table the risk of all of these, cardiometabolic things. And this study, they just stratified mild and severe psoriasis. We usually have those 3 categories, but they just did 2 categories. So mild was less than 3%, and then severe was everything else. But again, that trend continues. With the more severe disease, the higher the relative risk of having heart attack, stroke, cardiovascular death and MACE weren't done, but diabetes and especially chronic kidney disease, which is something I never really thought of before. But chronic kidney disease significantly increased in our severe psoriasis patients. They're way more at risk of having a MACE event than having a melanoma. And I thought about this when I was going through the slides. We do a skin check on all our patients, pretty much every year. And so we're screening for melanoma. But the risk of that is so much lower than them having a heart problem. So I think it's just, making the point to screen our patients more often. Keep it in mind. These are guidelines that the AAD, the American Academy of Dermatology, and the NPF did in 2019. I'm not sure when they're going to do another, probably in a few more years. But basically, the recommendation is anybody who has a heartbeat and meets certain criteria, age, whatever, they should be screened according to the national guidelines for hypertension, diabetes, and hyperlipidemia. So you guys all know those criteria better than me. But the second line is that if our patients have more than 10% BSA, so severe psoriasis, or if they're a candidate for systemic therapy or phototherapy, so that's where we can encompass our special sites. If they have either of those, then they should be screened earlier and more frequently. So the big question is, are the treatments that we're using for skin and joints impacting cardiovascular health? Are we reducing their risk? And the jury is still out. I think we all hope so and expect so, but we don't have a lot of data to prove that. So first of all, we don't have a great understanding of what is the best test to do to check for vascular inflammation. So there are many options, and a lot of us use CRP. We use other tools to determine that risk. And then we also don't know what is the best treatment for reducing the cardiovascular risk. So there's some data from rheumatoid arthritis studies that suggest that methotrexate and TNF inhibitors have a positive impact, likely due to reducing overall inflammatory burden. And there are some observational studies that cautiously suggest that biologics do the same, but we don't know which biologic is the best. We don't have enough data, so we really need long-term randomized controlled data, but I think that is going to be a focus on the coming years.
Yeah, and there was a study that was about a year and a half ago with apremilast, also known as Otezla, which did show an improvement in patients' cardiometabolic profile. So Otezla is an oral systemic drug that's taken twice daily for our mild, moderate, and severe plaque psoriasis patients. There's some caveats and nuance with that medication, which we'll go through later. But that was actually within the past year and a half where the study actually focused on improving the patient's cardiometabolic profile and being on a psoriasis systemic. And apremilast did show a significant improvement in that cardiometabolic panel.
Yeah, I think more studies are probably coming. So I found this study recently, and it shows the cytokines on the right, which Eileen spent some time talking about at the beginning. And so we know that those cytokines are involved in creating plaque psoriasis on the skin. And it's interesting because if you look at an atherosclerotic lesion, those same cytokines are expressed. And so it stands to reason that by using those anti-cytokines, we will be helping to improve those plaques. So I think that, again, more data is coming. This is from the same study, and it talks about, well, it's a nice algorithm. I think we all love those. It talks about how to screen your patients for those cardiometabolic concerns. So in the blue box, I know it's kind of small, again, if they are a candidate for systemic therapy or phototherapy, or if they have greater than 10% BSA, then you screen for lipids, hemoglobin A1C, blood pressure. You check their history for increased risk. And then, it takes you through if there are lab abnormalities, if they have high risk, like history of smoking, high BMI, then you would consider earlier referral for cardiovascular, cardio care and stuff, and interventions like that. So I think, the data is coming that we need to do that more regularly. So something else we always worry about is malignancy and psoriasis, and whether our psoriasis patients have a higher risk of malignancy. Of course, it's a concern in any inflammatory state because pro-inflammatory states usually are thought to be associated with higher rates of certain types of malignancy. We also use a lot of immunosuppression, and so how does that play a role in malignancy? What if our patients have a history of malignancy? How does that impact what treatments we choose? And whether the medicines we pick are increasing the risk of malignancy, or is there a baseline risk in our psoriasis patients? We do know that lymphoproliferative diseases, lymphoma, those tend to be more represented in our patients with psoriasis and psoriatic disease. We see increased rates of cutaneous skin cancers. When the studies were done on the first TNFs in the early 2000s, the end of the last century, a lot of those patients had been treated with immunosuppressants and PUVA, which I'm going to talk about, a really aggressive type of light therapy that was very effective, but also increased their risk of skin cancer, we now know. So a lot of those early studies showed that these patients had high rates of skin cancer, including melanomas. And the patients that are in the studies now, a lot of times have not been exposed to such high, phototherapy, long-term phototherapy. So those don't seem to show a red flag for skin cancer. So it's still, to me, a little bit unclear whether there really is a risk from the medicine or if it is the previous treatments. But in any case, we do screen for that. And I was thinking about that first patient that Eileen had up here with the back, where the person was really covered, and then the next slide showed the clear. Imagine trying to screen for skin cancer or melanoma. Like, you couldn't read that tattoo on the lower back, let alone see if a mole was abnormal. So the medicines are really helpful in reducing the risk of skin cancer by just screening earlier. And then we have new small molecule medicines, newer biologics. We are collecting data ongoing, but they seem to be, the biologics especially don't seem to really show an increase. Some of the small molecules, question mark. Okay. So lymphoma is the thing we think about the most with our psoriasis patients. There is an increased relative risk of certain types of lymphomas in our mild and severe psoriasis patients. But if you look at the bottom of that table, the T-cell lymphoma, so CTCL, cutaneous T-cell lymphoma, is an uncommon type of lymphoma, but it can look a lot like psoriasis and can be really challenging to diagnose, because even if you biopsy it, a lot of times it's hard to tell what it is, as we've talked about with psoriasis in general. So some of our patients who we think have psoriasis may actually go on to be CTCL, and so there is an increased risk of that. And whether it was always CTCL or if it evolved, it's a little bit difficult to tell. And then again, melanomas and skin cancers, relative risk with the TNF inhibitors. So those are the earliest biologics that we studied in the early 2000s, slight increased risk. So I just adopted screening everybody once a year on all the biologics. Is that your?
Same.
Yeah, that's your policy too. So if you have a patient who's on a biologic, you can ask them if they're getting an annual skin check. We're happy to do that, and that should be part of their care. I usually sync it up with when the PA needs to be renewed, when we have to do their quantiferon tuberculosis blood test, and their skin check. It makes it simpler, I think.
Yeah, and the joy of being able to prescribe some of these biologic medications is they come in and they're usually pretty clear. So I start to find out the name of their cat and the feud that they're in with their neighbor. And I'm like, well, while you're here, let me just look you over, because the beauty of these medications, we're getting people 90 to 100% clear. If we're seeing these folks every 6 months, I even have some that I see once a year, there's really not much to do and see. So I use that opportunity to say, when's the last time you had a physical? Would you like me to check your vitals? Can I look over your moles and spots? And that is the beauty of having a lot of these medicines at our disposal.
It's true. Malignancy screening is the standard that's recommended based on age and risk. So nothing different, nothing advanced for patients with psoriasis. Okay, mood disorders. So this slide I think is really impactful. So there was a study done in the UK with thousands of patients with and without psoriasis, and they found that there was an increased risk of depression, hazard ratio of depression, anxiety, and suicidality, which they included with suicidal attempt and completion. And so, as Eileen mentioned, a lot of our patients are living with pain. We haven't really talked that much about itch. I feel like I used to think of psoriasis as extremely itchy, but really it's not as itchy as something like eczema. Is that what you find?
Yeah, and I think there's been a lot of emphasis on eczema being the itch that rashes. So maybe itch kind of gets put to the wayside with psoriasis, but I think it's definitely a subjective thing.
Yeah, but it can be itchy. And pain, stigma, et cetera. And also, we used to always think that patients were depressed because of their skin. But those same cytokines that are involved in psoriasis are also involved in depression and expressed in higher levels in depression. So I think it's a two-way street there, where the cytokines could be also triggering the depression, not just the look of it and the stigma and the discomfort. Agree?
Agree.
All right. This slide I also think is extremely impactful. So patients were asked to rank how much their disease bothered them, and higher numbers were worse. So they asked them about physical ranking and also mental ranking. So the scale was up to 11. And so if you gave your disease an 11, that meant it really, really bothered you on both ranks. And if you look at the bar that goes the furthest to the right, that's psoriasis. So it ranked 10 out of 11 compared to all of these other diagnoses. So heart failure was worse in terms of physical ranking, but psoriasis beat out cancer, hypertension, heart attack, etc. And then the mental ranking, it was 9 out of 11, which is significant for, if you have cancer, I feel like that's obviously extremely stressful and it will impact your mental state. And then if you add the total, it was the worst. So psoriasis is something that we've been saying this. You guys already know. You shouldn't underestimate how much it impacts our patients. And even healthcare providers have a misconception about psoriasis. They sometimes think it is this is the lay people, but then also the study on the left includes med students. So this is desire to avoid doing the behavior. So they would avoid shaking hands. They wouldn't want this person in their home. They wouldn't want this person to marry into their family. And then on the right, it's talking about whether they think it's contagious, that it only affects the skin, and that it's not serious. So there is definitely a big misperception about what psoriasis is and how it is spread, it's not contagious, and how it impacts the patient who has it. Smoking, so it's very interesting. Patients who smoke have an increased risk of psoriasis. So the more cigarettes the person has smoked, the higher the relative risk of developing psoriasis. So I know we're already telling our patients not to smoke, but it's another reason not to. However, you can get them to quit, right? Okay, I'm gonna spend some time on psoriatic arthritis. We've already talked about it a bit. It's the most commonly asked about comorbidity, I think, from dermatology, and it's a pretty easy thing to screen for. So I think that we can all probably incorporate asking about psoriatic arthritis into our daily practice. So again, about 30% of patients will have psoriatic arthritis if they have psoriasis. Age of onset is variable, most common 30 to 50, equal male-female distribution. Usually the skin presents first. It is a destructive form of inflammatory arthritis. It leads to disability and loss of function that can be significant, and prompt diagnosis and treatment are really imperative. There's no biomarker, so you can't do a blood test. It's a pain. So if anyone wants to be a millionaire, figure that one out. This is a graph showing that 75% of patients start with skin, 10% have arthritis first, so again, it's unusual, and then about 15% it starts together. And here are some pictures of how destructive it can be. Top left, you can see the deformities. Bottom left, you can see more deformities. On the right, it's a little bit more subtle, but you can see the beginning of the deformities. So it's really common that psoriatic arthritis goes undiagnosed, and these next stats are, I think, really important. So if you delay by just 6 months in sending them to rheumatology to get diagnosed, there can already be significant disability and joint damage in those 6 months that before they were seen. And it's terrible because I feel like it's really common to have a 6-month wait to get into rheumatology. Enthesitis and dactylitis signal erosive forms of psoriasis. I'm going to go into what those are on the next couple of slides. And 47% of patients can have erosive disease within the first 2 years of having psoriatic arthritis. So it starts and it ramps up quickly. It can be just misdiagnosed. Patients think, oh, my fingers are sore, my heels are sore, maybe it's plantar fasciitis. They ignore it for a while, and it's not reversible. So what is done, and then you're just trying to prevent it from getting worse.
And then the hard thing is too, let's say you do get that psoriatic arthritis patient and they do have psoriasis, and we try to treat them with one of the drugs and their psoriasis improves, but their joints don't. All right, they're a psoriatic arthritis patient. What part of this persisting chronic pain is now from the prior erosive disease that is not reversible? This is a progressive disease. So a lot of times we're treating their psoriasis, they're getting clear, and their joints aren't as good as you would expect. A, is there a misdiagnosis? Or B, is this indeed a psoriatic arthritis patient, but these patients have been stewing and simmering so long that erosive disease has become so advanced that they're dealing with chronic pain. So that can be a very difficult conversation to have, and it can be frustrating on both ends. And sometimes it requires us to envelope you guys and other ancillary specialties to try to get these patients comfortable.
On the flip side, one thing that's very nice is that when you put a patient on a biologic and you've been asking them all along if they have joint pain, and then they didn't realize they did, and they feel so much better on the biologic, and they had no idea that they were living in pain because they were just so used to it. So that is very satisfying. So there are some silver linings. Okay, so the PEST tool is really easy. It is a 5-point questionnaire that you can ask as, well, I say as I'm doing a skin check, but hopefully you guys can also take some away from this. So have you ever had a swollen joint or joints? So, it could be any of them, usually fingers or toes. Has anyone ever told you you have arthritis, a provider? Do your fingernails or toenails have holes or pits? So is there nail involvement? Have you had pain in your heel? And it's usually just like plantar fasciitis, where it's the first thing in the morning. I say, when you first step out of bed, do your heels hurt when you first stand up? And have you ever had a finger or toe that was swollen that wasn't, from trauma? So no other reason for it to be swollen. And if they answer yes to 3 or more, then you can refer them to rheumatology, and it's something that we recommend you do at each visit. So there are different presentations of psoriatic arthritis. The distal predominant is the picture on the bottom left, where distal PIPs are involved, so they can be red or swollen. It doesn't have to be symmetric, and it doesn't have to be every single joint. Oligoarticular is less than 5 joints, again, usually asymmetric. Polyarticular can be really tricky because it can look like RA, where it's more than 5 joints involved. Spinal involvement. So I used to hate asking people if they have back pain, because everybody has back pain, and then that's all you're going to talk about for the rest of the visit. But there are certain things. So I don't say, do you have back pain? I say these specific things. Have you had chronic back pain for at least 3 months? Did it start before you were 40? Is it better with exercise and worse with rest? So it's like the opposite of RA. So with psoriatic arthritis, the more you move around, the better it feels. Whereas with RA, generally it gets worse throughout the day. Do you have early morning stiffness? Or this last one is very specific. Do you wake in the second half of the night with back pain? And that's because you've been still for a while. And if any of you need to stand up and stretch, go ahead. So I asked those very specific questions about back pain. And then arthritis mutilans, which we're really trying to prevent, is these telescoping fingers where there's bone resorption, and that is the most advanced destructive stage of PSA. So dactylitis is the fusiform swelling of a joint, a finger or toe. It looks like a sausage digit, and it can be mistaken for gout, and it's common in present in about 40 to 50% of patients with psoriatic arthritis. So I feel like this is something that's very easy to screen for. And if you describe it as a sausage, patients will easily know what you're talking about. Enthesitis, so the enthesis is where the tendon or muscle inserts into the bone, and it's a really common site of inflammation for psoriatic arthritis. The most common one we think of is the Achilles tendon on the back of the heel, present in about 40 to 50%, but there are other sites that can be involved. Axial disease, this is basically what I already spoke about, but asking those very specific questions. Ankylosing spondylitis, sacroiliitis are forms of psoriatic arthritis, and about 40% of patients with ankylosing spondylitis will say yes to these questions that we talked about. And then we already talked about nail disease and just screening for it. The only time it's really tricky is if people come in with their nails painted, which is common. So, that's an issue. But if you can visualize their nails, it's easy to take a look, and it helps you rule in or rule out psoriasis. All right, I'm going to do a brief. Oh, wait a minute. That was weird. Did I go? Okay, treatment. Oh, no. I got myself discombobulated. So psoriatic arthritis treatment differs but overlaps from treatment with psoriasis. So as Eileen alluded to, we want to try to give as few medicines as we can to treat as many diseases as possible. There are behavior modifications that patients can do: weight loss, smoking cessation, physical therapy. There are conventional DMARDs, disease-modifying anti-rheumatoid drugs, that are really commonly used in rheumatology. They seem to put everybody on methotrexate. Sulfasalazine, probably less commonly used. Hydroxychloroquine, leflunomide. The problem with hydroxychloroquine is it is one of those medicines that can flare psoriasis. So I like to ask about whether that when they started the hydroxychloroquine, did their psoriasis get worse? Not always, but it can happen. I've seen it happen. They can inject joints. There are small molecule medications, which Eileen is going to go over, and then biologics. So a lot of the biologics do have indications for both psoriatic arthritis and psoriasis. The ones in green are FDA approved for both. I think for the sake of time, I'm probably not going to spend too much time here, but just know that there are medicines that we can use that address both. Okay, and then other comorbidities that are ongoing and coming out and we're gaining more information about, inflammatory bowel disease. It's interesting because if you look back at the TNF inhibitors as an example, because they have 10 indications, one of which is psoriasis, and another is psoriatic arthritis. They also have indications for other inflammatory diseases, and to me, it's interesting that now we're finding out that they're all kind of linked, you know. And a lot of the newer medications also have indications for inflammatory bowel disease. So patients with psoriasis also have increased risk of obstructive sleep apnea, again, chronic kidney disease, which I mentioned, periodontitis, osteoporosis, uveitis, COPD, and autoimmune thyroid disease. So these are conditions that if patients have it, it probably will help you to diagnose psoriasis. And then the flip side, if they have a diagnosis of psoriasis, it's some other things to keep in mind. Make sure people are going to the dentist, as they should, getting their eyes checked, etc. So to summarize, for psoriasis, it is a chronic immune-mediated inflammatory disease with many comorbidities that we're unfortunately realizing more and more. But we have an opportunity to really incorporate other specialties to try to give our patients the highest quality care that we can. An informed patient is an empowered patient. So it is difficult, and we can talk about this for a minute, how to break the news to somebody, about psoriatic disease. A lot of my patients already have, know they have psoriasis, but if they come in and you do make that diagnosis, it's a little nuanced giving them all the information about comorbidities. Probably start with one or two, do a screening for maybe a few of them. And then as you build that trust and relationship, you can go more in depth. As you're saying, when their skin clears, then maybe you're asking, when was the last time you went to the dentist? Things like that. What about you?
Yeah, I think it can really hit them over the head if you really try to, and especially with the schedules that we run, it's not uncommon for us to see 35 to 45 patients a day. So our new patient visits are 15 minutes, and we have ancillary staff to really help us run as efficiently as possible. But I also allow kind of that intake form that they updated every visit to help guide, okay, there's been changes, or I see that you're on high blood pressure medication, et cetera. But I really, when I see a psoriasis patient, I always tell them, my commitment to you is that I'm going to be with you through this whole psoriasis journey, even when you feel like you don't need me anymore. So I use that kind of journey philosophy to say, look, along the psoriasis journey, first and foremost, my goal is to get you clear. I'm going to give you a little bit of extra information perhaps about your joints. And then, as we continue to meet and this relationship evolves, we'll really make sure that we're covering all our bases regarding what we know about different things you could be at risk for down the line if your psoriasis is not treated. And you don't want to use that information as a weapon, but I have a lot of patients who come in and they're covered with plaque psoriasis and they don't want a systemic medication. You don't necessarily want to use it in a threatening tone, but I think there's a way and a nuance to go about and say, hey, look, there are risks of unmitigated inflammation running through your body like you have at this point in terms of cardiometabolic cancer. Again, you don't want to scare anybody, but using this information to empower them and reassure them that they're actually choosing a medication, and that is actually a step towards an overall better state of health.
I agree. Psychological impact is too often overlooked. So again, check. We can sense their mood, their affect, pretty quickly. So something that we can delve a little deeper into if it seems like there's a red flag there, and comprehensive care, talking about comorbidities with our own self, thinking about what else we need to screen for. Okay, so treatment. We've talked about the hand being 1% BSA and the categories of mild, moderate, severe. So I think we can go past this. There is a tool that you'll see if you read a lot of research papers on psoriasis called PASI, Psoriasis Area and Severity Index. It's really a research tool. It's not something that we generally put in our note, but it is something that is used to assess generally severity of disease and then also improvement to treatment. And so, this is an example of a patient who initially has like baseline psoriasis, and then in the middle picture, 4 weeks later, they have a PASI 75. That equates to about 75% improvement, and then PASI 90 on the far right, which is about a 90% improvement. And, when Eileen and I were growing up, like PASI 75 was amazing. If we can get you 75% clear, like that was, earth-shattering, because creams couldn't do that. Now the standard is really 90, even 100% in a lot of our newer biologics. So, just keeping in mind with certain treat to target goals that we have for our psoriasis patients this day and age. So we've mentioned topicals. We've talked about topical steroids. They really are the mainstay of treatment for limited plaque psoriasis. We do have to keep in mind the site we're using it, the age of the patient, the cost. So this is just a chart of where you can use stronger medicines and weaker medicines. So it's, I think, pretty self-explanatory that you want to avoid using really strong steroids on the face and the genital area. You want to reach for your milder potency steroids in those areas, and then you can go stronger as the skin gets thicker. So palms and soles, the skin is extremely thick, and it can take more high potency steroids. Little babies, you want to use milder medicines. It's not uncommon in kids, but still, think about their age and also the vehicle. So steroids come in a million forms: shampoo, gel, foam, spray, solution, cream, lotion. It might be everything. So when you're distributing it, think about where the patient's going to put it and imagine yourself putting it on. I was thinking about this morning, and you mentioned it as well. But when I got dressed, I just put my clothes on. I didn't have to spend 10 minutes rubbing this gook on my skin. Keep in mind the area that the patient is going to have to put it on. You're not going to prescribe an ointment for the scalp, right? Maybe if they're bald. But, really think about yourself having to do it, regularly for days. And I think that helps you figure out what would be good. I really like liquid for the ears, drops. There are some topical steroids that come in drops, which are good for the ears. So, things like that. And then I also try to give them fewer tubes or fewer prescriptions. So if it's possible to do one for multiple areas. So like, let's say they have their ears and they have a little bit on their elbow. I say, listen, I can give you one. It's going to be liquidy. I think you can still get it onto your elbow, and then you'll only have one medicine instead of two. So, cost and convenience. Any tips on that?
Yeah, agreed.
All right. So we have some new topicals, which are wonderful. So they're two that are brand new that are non-steroids. So it's really nice, again, because then you can use it on multiple body sites. You don't have to worry about the possibility of discoloration in our darker skin patients. You don't have to worry about how long I've been using it. You got to take breaks from it. I love talking about this one, tapinarof, because it's a brand new medicine. It's a brand new molecule. So it's an aryl hydrocarbon receptor agonist, which if you say it just sounds smart. And what it does, instead of everything else that we have, which is suppressing or reducing the bad stuff, this enhances the good stuff. So it increases the hydration in the skin. It does suppress the secretion of those cytokines that are involved, but it really upregulates the good parts of the skin. So it helps with the barrier proteins. It helps with hydration of the skin. And a lot of patients like that. I think part of it is I'm excited when I explain it. But then also I think patients are interested in something that's just increasing the good parts that are already there. It's also once a day, which is nice. It's only FDA approved for 18 and up, so it's off-label for people under 18. But it works pretty well, So PGA is Physician Global Assessment. 0 or 1 means clear or almost clear. And they had a 2-point improvement, so that means they went from like a 3 or a 4 to at least 2 points higher. And it happened in 36 to 40% of the time. That's just with a topical once-a-day medicine. So, it's something that's fairly convenient. It can be used in combination with other treatments. So if you have somebody on phototherapy or a biologic or whatever, you can also give this to them for those spots that might be more stubborn. Side effects were mild. coverage is an issue for me, at least. Roflumilast is a PDE4 inhibitor. We have another PDE4 inhibitor that was approved a long time ago for eczema, atopic dermatitis. This is a new version. It's a different medicine, but it's that same type of inhibitor. It comes in a cream and now, most recently, a foam. I think I forgot to list foam in the vehicle options. So this increases CMP, which downregulates inflammation. It's also once daily. The cream is FDA approved for 6 and up, the foam for 12 and up. Similar efficacy, about 40% of patients achieved an IGA success by week 8, some as early as week 4. Can be used in intertriginous areas, which is nice, with a really high success rate there. Side effects are low. My issue is usually getting it approved for patients. Usually they have to do step therapy. Usually they'll have to try one of these. So we have calcineurin inhibitors, tacrolimus and pimecrolimus. These are non-steroids. They are FDA approved for atopic dermatitis. It is off-label for psoriasis, but we do use it for all kinds of different inflammatory diseases as a steroid-sparing agent. They can sting and burn when you first put them on, so I've warned all my patients about that. If you put it in the refrigerator, it tends to sting less, but most of the time as you keep using it, the stinging and burning reduces. Calcipotriene is, I would say, not that often used. It's a vitamin D analog. It's not going to do any harm, but it's not that effective in my hands. And then same with the keratolytics. Eileen and I were talking about this last night. I feel like we hardly ever use these anymore, but they're still around. Keratolytic means it's going to thin out the keratin, the thick plaques. So sometimes they're helpful if you are trying to do topical treatment and you're putting the medicine on. It's trying to get through that oyster shell, and it can't. So if you thin out that scale, it will actually get to the part of the skin that needs to be treated. But these are just other options that are available. Again, tazarotene, it is FDA approved for psoriasis. It's a category X, meaning it's not, it's contraindicated in pregnancy. It's a topical retinoid, not that commonly used. Anthralin is currently off the market, but it was something that we used for psoriasis. And then there are some combination products that are convenient, but I find difficult to get approved through insurance. Okay, and just one quick slide on integrative medicine, because this is a field that I think a lot of us have an interest in and can be incorporated into traditional American medicine. So integrative medicine can improve quality of life and lead to changes in lifestyle. There are studies that have shown that probiotics can improve PASI scores and reduce inflammation and increase quality of life. There are specific types of the bacteria here, the probiotics, that were recommended in some studies. This is a pretty easy thing for patients to add on to their treatment armamentarium, their daily supplements. Weight loss can be an effective way of increasing skin clearance. The low-calorie diets, and then also the new GLP-1 inhibitors that a lot of patients are on. I'm really excited to see how those play a role. Studies have shown that patients with higher BMIs respond less to their treatments. So as we reduce people's BMI, get them to a healthier weight, it's going to be interesting because they should respond better to treatment. And then, as we know, adipose tissue is pro-inflammatory, so they'll be in a less pro-inflammatory state. They recommended high-protein diets, specifically plant-based protein, reducing red meat to help with inflammation, and then just that it's important to do weight training and low-intensity cardio activity. So these are things that we can suggest for our patients. It might be helpful to have like a handout on this. You don't have to spend a lot of time on it, but you could say, here are some options that are like a little bit more homeopathic and holistic. Okay,
there's a great physician out there. Sorry, Tori. His name is Dr. Leo, L-I-O. Peter Leo. He's out of the Chicago area. I have a lot of patients that want to come in and they want an integrative medicine perspective into their inflammatory disease. He actually prescribes all these drugs we've been talking about, but has a really amazing integrative medicine component to his practice. He has a portion of it that's online. They have like support groups, they have chats, etc. So Dr. Peter Leo, L-I-O, not only is an amazing clinician, but he's a wonderful man. He's a really great resource for a lot of the integrative kind of naturopathic perspective of treating some of these inflammatory dermatoses. And I have a lot of patients who have insurance access issues, and that can be one of the driving factors that they want to treat their psoriasis or inflammatory condition a little bit more naturally or in a homeopathic perspective. And he's a really great resource.
Yeah, he is. He has come up with all kinds of really cool things, like using tea and vitamin B cream and stuff. It's neat. Did that skip without me? Okay. So we've talked a little bit about phototherapy. There are 2 rays of light that are involved in phototherapy, UVA and UVB. I mentioned UVA is, well, I might not have said this out loud, but UVA is a more energetic wave. It penetrates deeper into the skin. We used to use it a ton for psoriasis and for other conditions too, but now we know it has a higher, it causes melanoma, basically increases your risk of melanoma, so we really don't use it very much anymore. Narrowband UVB is viewed as much safer and still very efficacious. So if you think about it, the sun is radiation, so it is suppressing the immune system. And so UVB phototherapy is synthetic sun. So, we have overactive T cells that are driving this process of psoriasis, so we're reducing that activity. And so it does all of the good things to the skin when patients have psoriasis. So there are risks and benefits. With UVB specifically, they can burn. The UVA ray is thought of as the tanning ray because it basically skips the epidermis and just goes to the dermis, so you don't have that red peeling effect from it. With UVB, you can get a burn. There was thinking that it increased your risk of skin cancer because we just thought if people had more sun, they would probably get more skin cancer, but that actually isn't looking like it's really a concern. If you're doing it on a patient in an area where they have a history of HSV, herpes, cold sores, it can reactivate it. We usually shield the face in our phototherapy unit, so that's less of an issue. It can be costly. Some insurances won't cover it. They'll have a copay every time, and they have to come into the office to have it done most of the time. So that can be, sometimes it's just not practical, and it doesn't treat the joints. But it is viewed as safe, it's efficacious, it's steroid sparing, and it has a pretty tolerable side effect profile. So this is a picture of a typical narrowband phototherapy unit. The door in this picture is open, but the patient steps in, closes the door, and there are lights on all sides. It's done generally 3 times a week, and the treatment starts with a certain number of seconds based on their phototype, skin phototype. So more light patients will have less time in the booth, and then our darker patients will naturally start at a higher length of time, and then every time they come in, it increases by 10%. So if you start with 30 seconds, then the next time is 33 seconds, and then it's 36.3, whatever. It goes up every time. Okay, and then PUVA. Oh, sorry, this is excimer laser. So this isn't really a laser, it's just narrowband on a laser device. So it's focused phototherapy. And so it's great for people who have only a couple of spots, so you don't need to put them in the whole booth to expose their whole skin. You just have them come in, and a nurse or a technician administers the phototherapy to those specific spots, generally twice a week. It does take several weeks to see the improvement. And then once we get them clear, they stop doing phototherapy, and then they start it back up again if needed. This is just what PUVA looks like. It's used rarely anymore, but we used to use it a lot. So it's something that you're probably not going to see very much. Okay, to summarize, topical therapy as monotherapy is best for limited disease and or special sites or as a supplement to other treatments. You got to really think about the potency of the steroid that you're prescribing, the vehicle, how much you're giving them, and then potential side effects from putting it on. There are many steroid-sparing agents that are out there now that are really great. Some of them even have evidence that they can really decrease recurrence of the disease, so that's exciting. And phototherapy can be a great treatment, but you have to have a local place where they can go. It has to fit with their work schedule, and cost can be an issue. All right, so now we're going to move into more systemics. Great. Thanks, Eileen.
Yeah, Tori had alluded to some of those newer molecules, which are really great for psoriasis because it really eliminates the recipe card where, okay, one lotion or solution for this, and then this cream here, and then this ointment here, because of the number of products and the location and the potency. Those non-steroidals are great because it's, one product for all these areas. And as she alluded to, I think the biggest prohibitory factor is cost. So a lot of our practices use local specialty pharmacies. So find out if you have a specialty pharmacy in your area. And a lot of them have these huge just electronic walls or actual walls where they have all these little discount cards for these brand-only drugs. And if they're commercially insured patients, in at least the state of Massachusetts, they can have access to these drugs for little to no copay. So it's very hard to get some of these specialty drugs to the local CVS or Walgreens. That just doesn't happen. So that's just a little pearl that if you want to dabble into those, do it. Go ahead. You're going to need to find a specialty pharmacy in your area that will usually want to help you fill a brand-only drug. Okay, so we're going to talk about systemic agents. When we talk about systemic agents, we're going to talk about oral and biologic medicines. I'm really only going to spend about the next 15 minutes, and then we'll hopefully have some nice Q&A to wrap up today's session. So we're first going to talk about the oral medications for psoriasis. So when we look at the oral medications, there are a number of them. Some are more traditional, and some are seen as a little bit more new-aged or advanced. We're going to briefly take a look at what these drugs can do in terms of their firepower or their efficacy, and who's the best candidate for them. What are the pros and cons, risks and benefits of being on these medicines, and who is that next patient that belongs on an oral medication? So as Tori had alluded to, there were a lot of these traditional paradigms that we would use to fit patients into a box. You have mild psoriasis, you have moderate psoriasis, you have severe psoriasis, and it's because of how many palms worth you have. And we talked about that. Here in 2025, we really have much more freedom and flexibility as providers to be able to determine who truly is mild, moderate, and severe outside of how many palmfuls they have. And the reason we have that autonomy and freedom is because of councils like the International Psoriasis Council. They actually got together and put forth Delphi working guidelines that say if you have a patient, sure, that has 10% or more of their body covered, yes, they're a candidate for systemic therapy. But also keep in mind, if you have patients who have psoriasis that are on sensitive or special sites, or if they have tried a topical, it can just be one, and they're not doing well, these patients can automatically be front of the line, fast track to systemic therapy, oral or biologic medications. So no longer are we hamstrung by having to have this body surface area characterization. I use these guidelines a lot when I have a patient that has a low body surface area, but a very high impact of disease, a genital, a scalp I can't get clear with messy topicals. I send these guidelines in with my insurance authorizations all the time, and they're just a nice way to be able to get some of these systemic medications approved. So the newest oral medication on the market is deucravacitinib, Sotyktu, 6 milligrams. Long story short, this medicine works on that IL-23, IL-17 axis. So the big communicator or mediator of the messaging from 23 to 17 is TYK2. And TYK2 is another one of these molecules that works to help promote that psoriasis cascade. It works intracellularly, and it's the messenger between 23 and 17. So if you cut off the messenger, you improve the psoriasis. It's by mouth, 6 milligrams once daily. Some pretty decent efficacy for an oral medication taken once daily, where we can see about 6 in 10 are getting that 75% improvement. And there are some patients that are getting that clear, almost clear skin. This medication we see when it's taken once daily, it's pretty easy in terms of getting them started. Because it is a medication that works on that 23-17 pathway intracellularly, we do get a tuberculosis test on all of our patients just with the rare possibility of TB reactivation. So these patients are getting a TB test of our choice to make sure they don't have TB. And then we'll automatically look at their liver function, triglycerides occasionally, just to peek behind the curtain. But this is a medication that I say, check their TB and get them started. Upper respiratory infection, because we're immune modulating, it's a risk you're going to see throughout the next few slides with these systemic medications, and nasopharyngitis. So who do I prescribe it for? A patient that has that psoriasis, that doesn't want an injectable medication. They want a pill that they can take with them. They want to be able to just dose it once daily. So this is for 18 or older at this point for adults that have psoriasis. The psoriatic arthritis indication is coming, but right now that patient that has psoriasis that wants to take a pill once a day, that wants that efficacy. It's slower though, so I tell my patients these are not the quickest molecules. This one tends to take a little time to get improvement. Methotrexate, definitely traditional, definitely old school. I usually use it at this point as a bridge. Insurance company isn't covering one of the newer agents, so I'm forced to put them on a traditional agent. Methotrexate, as we know, it activates folic acid and it reduces the thickening in those plaques, decreases pro-inflammatory cytokines. And there's some decent efficacy, 4 in 10 get that 75% improvement. But the biggest thing with methotrexate is safety. And it's funny because our rheumatology colleagues make fun of us. They give out methotrexate like Skittles. It's like methotrexate here, there, everywhere. It's cheap, et cetera. And I'll be honest, some of that has rubbed off on me. If I have to put them on it, I do it without hesitancy, but it's just not my first line. But the biggest thing is liver function and cumulative dose over time. So I have these patients that come in and they've been on methotrexate for the last 20 years. It's like, has anybody checked any type of HEPA score on them to check for liver fibrosis? So it's not something that we're running into a lot because most of us are using it for such a short amount of time as a bridge to something else. But liver function is the biggest thing. And because of the folic acid activation, these patients have to be on folic acid supplementation. And it can sometimes help with the side effects where patients have GI upset and they're a little bit tired on the medication. Not used very often. Where am I prescribing it? In patients who need a bridge to something else typically. Works good with joints too. Soriatane, this is psoriasis's version of Accutane. So we have our acne patients who use isotretinoin, a vitamin A analog to treat their severe nodulocystic acne. This is psoriasis's version of Accutane. It's an oral retinoid that helps slow down the proliferation of those keratinocytes I talked to you about. Remember, the power of those keratinocytes is really powerful. They take it once daily. Biggest thing is just like with our retinoid patients in the Accutane space, there's dryness, there's lab monitoring that's on it. We cannot have any female patients on this medication. They can't get pregnant while they're on it, and then they have to avoid getting pregnant for 3 years after stopping the drug. About 4 or 5 years ago, I had a patient come with me to visit for me the first time internationally, and she brought a bag and she opened it. She's like, I want more of this. And she was 24 years old and she was on acitretin from another Middle Eastern country and asking when she can get pregnant. No clue, no idea. Got it at a local apothecary in the country in which she lived. So this is a medication we really avoid. Good for palms and soles. It tends to be more expensive though for some reason. It's been around forever, but it's very expensive. So those are the patients I typically use it in. That's a little edit slide we don't need to cover. I meant to look at that. Otezla, apremilast, I mentioned it and alluded to it when we had the comorbidities talk. This is also an oral PDE4 inhibitor. So Tori talked about a rub-on topical that inhibits PDE4. This is an oral PDE4 inhibitor, been around for a while, 6 years or older, who have plaque psoriasis and also has a psoriatic arthritis indication. This is not immune modulatory, so there is no baseline blood work that has to go on with these patients. It is not immune suppressive. The biggest thing with Otezla is tolerability. I have a lot of colleagues who are in the primary care family medicine space that prescribe Otezla, and they are always asking me about tips and tricks to manage the side effects. And the side effects is GI. It's cramping, it's diarrhea, it's stomach upset, sometimes it's headache, nasopharyngitis. This drug is very easy to prescribe. Its cost is also going up, but I can tell you there's a lot of nuance about side effects with it, and it's really GI. So there's a starter pack that comes with it and some little off-label tips and tricks we give our patients to try to go through it. But the biggest thing is the GI, and a lot of patients just can't tolerate it, even if we mess around with the doses. Comments about?
Yeah, I've gone to once a day instead of twice a day on some patients, but and usually the GI symptoms get better if they're able to continue taking it. Like, you kind of get used to it. But I've had, patients stop using it, even though their skin is getting better because they have diarrhea. Who can live with that?
And I'll touch upon it in a moment, some special populations for treating psoriasis. This would be a great drug, maybe for an older psoriasis patient, right? 65, 66-year-olds struggling with psoriasis. But here's the problem. Diarrhea, GI stuff, those are patients that can have hypovolemic issues very, very quickly. So if they're having GI issues, they're dehydrated, et cetera, to the point where there is an actual notation on the label of this medication that we need to be careful with patients who are susceptible to a hypovolemic state because of diarrhea, nausea, and vomiting. So there's a little bit of a paradigm there where this ideally doesn't have any immune suppression, no lab work, but the GI thing can be a real issue, especially in patients that can already be a little bit volume compromised. So orals are a great option. There's definitely a variety of them, with the majority of them being very easy to take. But what I'm going to show you over the next few slides, I think, is really the strong point. These oral systemic medications are not necessarily where it's at with efficacy. Every once in a while, you'll get a unicorn and be like, I can't believe I did that with an oral medication. But I really feel they're a great option for a number of our patients who have that moderate disease. They don't want a shot or they can't go on a shot, though there aren't many that can't nowadays. And then just making sure that you're talking with your patients, like, what are you looking for psoriasis treatment? And they may want a pill, and that's cool. But then the other side of that coin is I have to talk to you about what to expect if you're going to take a pill. And these are the general results of how long it's going to take to get there and what those results are going to look like. which really shifts me to my passion, which is biologics and psoriasis. These are medications that are delivered via injection, and we see them in a lot of other areas of medicine. You alluded to, inflammatory bowel disease, et cetera. So these drugs you'll see on your patient's med list for a number of reasons. But biologics themselves really are the most targeted for those inflammatory pathways with psoriasis. And what I'll do over the next few slides is just walk you through the ones that are very common in our space, tips and tricks, do's and don'ts, and who's the best patient for it. And again, we are fierce advocates for our psoriasis patients. We really do recognize that psoriasis patients continue to be really undertreated. And again, it can just be like, well, it's just a skin thing. Or the patients say, it's just the skin thing. But now I really hope after today's presentation, especially how wonderfully Tori did, was communicate that this is just more than skin. This is a multifactorial inflammatory disease. And getting on top of managing their psoriasis can really change the trajectory of their lives, not only medically, but psychosocially as well. And I also want to kind of just give a shout out to PAs and NPs. In the dermatology space, 70% of the biologics are being prescribed by us, you guys. So we are the ones that are in the trenches with these patients that are leaning in and saying, how bad is that one patch of psoriasis bothering you? When was the last time you had a physical? Let me take your vitals. And we're recognizing the importance of getting on top of these patients early. We are doing the hard work for these patients in our specialty. And you guys are doing a great job of recognizing who those patients are and getting them to us. The reality of statistics is 7 out of 10 biologics are written by providers like us. So you can trust us to make sure that we'll get those patients properly treated. So these came about in 2003. They are a specialty medication, and they're called a biologic because they were produced inside living cells, and they make, therefore, a very, very large molecule. I have questions come up when I have students, et cetera. Why can't patients just take a biologic by mouth? And the reason is these molecules are very, very, very big, and they can only be injected subcutaneously. At this point, I should say, because it's coming, at this point, if you were to, in theory, put a biologic down the hatch, the acidity of the stomach acids and enzymes would break it down and degrade it. And the fact that it's injectable means that most patients can go on these drugs despite these long medication lists they have. Because as we know, these oral medications, they swallow them, they go down through the GI tract, they go through the first pass effect through the liver, and we know that's a lot of where our drug-drug interactions occur. But when you have a medication that's injected subcutaneously, we know that you avoid a lot of those drug interactions. And we can see some of the suffixes associated with the medications. We currently have 12 to treat plaque psoriasis, and they are really selected to that target that we talked about. I'm not going to dive into this any more than I did earlier this morning, but we can see these pathways and where they land in terms of targeting psoriasis at these different levels. So we see IL-23 in the center. We see IL-17, TNF. We see a lot of these cytokines shouted out as main drivers of the inflammatory cascade. And it's lined up beautifully and very nicely here for you on the slide. So really divided into those 5 categories. Highlighted in yellow means that they treat both psoriasis and psoriatic arthritis, as Tori alluded to, and just little pearls. So if I go quickly from top to bottom, TNFs tend to be an older class. They really tend to shine in psoriatic arthritis, not as much in psoriasis. We have to be careful with our MS, our demyelinating, our CHF patients. They do have one drug that's actually very helpful in my toolbox, and that's certolizumab. That is safe in pregnancy. So there is a TNF that's in my toolbox quite a bit for patients of pregnancy potential or if they are pregnant and nursing. IL-12/23 was a newer agent that came about that was thought to be very effective, also called ustekinumab. Every 12 weeks, which is great, but then they found out that 12 isn't involved in psoriasis as much as we thought, and hence the emergence of the IL-23s, which have been the absolute blockbuster superstars for clearing plaque psoriasis. These drugs are getting us 90 to 100% clear with psoriatic arthritis coverage, very broad safety, convenient dosing. Mostly once you get a patient started on IL-23, they can go every 8 weeks. Some of them are every 12 weeks. And they don't want to move over the IL-17s, which have also been superstars in our space. You'll see those listed there. I don't mind shouting out the brand names. It's Taltz, it's Cosentyx, it's Bimzelx. These are really great in the skin and joints. The biggest thing is there is an inflammatory bowel disease signal, so we're asking your patients about their GI history if we're selecting a biologic. And this is just a shout out about special populations. Don't forget about pediatric patients. If you do family medicine, if you see all ages, all stages, we have drugs that can treat those psoriasis patients. We know the social stigma, what these kids are up against day-to-day lives in terms of their skin. So if you see a plaque psoriasis patient, please feel empowered to refer them to a dermatology office that sees kids, that really can advocate for that patient getting on drugs that are efficacious. Elderly patients as well, I alluded to some of the perils and pitfalls. There was a great article that came out last month that talked about advocating for elderly patients. They are traditionally undertreated as well because we're all scared. But there are drugs out there, particularly IL-23 drugs, that can change these patients' lives, and I've had a number in my practice. So typically, if I have a patient that comes in that's biologic eligible, I'll ask them about their medical history, I'll ask them about their comorbidities, and then I'll ask them, of course, about their psoriatic arthritis. If they're a female patient, ask about their pregnancy status, and just kind of get a feel for what these patients are looking for. You know, it's kind of like an a la carte menu. They can really pick what they want to do. Majority of the time, it's always TB. It's always TB. Hepatitis panel really came from the origins of the TNFs, but a lot of us just do it because it's colloquial. A CBC, a CMP, again, just to see how they're doing metabolically, right? No live vaccinations on biologics. So if you have patients that are traveling to endemic areas, they're going to go to, Carnival in Brazil, or they need yellow fever. These are just things we're telling patients. You can get the flu vaccine, you can get COVID, you can get Shingrix. Those are not live vaccines, but anything out the typical norm, I want to hear from you. And then we really do a great job of providing our patients support services to be able to help our patients through the process. Not only do we have many ancillary staff behind the scenes, but a lot of these companies have a whole suite, and I would even say concierge of services that can train patients virtually, come out to their house. They have these support services to get patients on drug and keep them on drug, because that's the biggest thing. These drugs are so good. These drugs are so good. It's not a joke, you guys. These drugs are so good. These patients are tempted to stop. And if it's like every 8 weeks, every 12 weeks, I'm getting a call from the pharmacy, like I can't get a hold of them, they haven't been on it for 6 months. So making sure that we set the expectations that these drugs are game changers, but they're game changers when you stay on the drugs. And then again, this really just, I think, does a nice job of buttoning this up for us. We are being as appropriately aggressive. We were bantering around if we should use that term or not. We really like to make sure that we're advocating for our patients as much as possible. And these are guidelines put forth from the NPF that really advocates for getting our patients to less than 1% body surface area 3 months after the treatment. Or they can have a treatment target at 3 months after the initiation of less than 3% or 75% improvement. And we don't want to use these treatment targets in a malicious way, but we really want to use them to hold us to a high bar and a high expectation, especially for providers that are hesitant to use systemic or biologic medicines. That's fine, but they should be getting them to providers that are comfortable doing so. So I'm going to go ahead and make sure you guys have the opportunity to look at this slide here. This is the QR code that has that enduring content for Veronica. It's the third final credit hour that talks about cases. And I'll give you guys a minute if you want to scan that QR code. And then I think we can open it up to questions if you guys have some. We have about 5 minutes left.
Yes. And so this QR code, folks, is also in the slide deck and the resources in the session description for this session in the Cvent app and the web platform. So if you don't scan this or you want to come back to it, go ahead and download that slide deck and you'll be able to come back and earn an additional credit hour there. Phenomenal presentation, ladies. Thank you so much.
Thank you for having us.
We do have some questions here with a few minutes. Let's get right to them. So the first one is, what dietary guidance do you provide your patients with regard to cane sugar, wheat corn, and GMOs in our food supply?
So I'll take that one. I don't spend too much time on diet because in all dermatology conditions, we always want it to be diet as the trigger or the cause, because it would be so easy to just eliminate one thing or avoid one thing and then clear your skin. Unfortunately, in studies, not just psoriasis, but on acne and other skin conditions, it really hasn't panned out. So there are certain food types, as I wrote on that integrative medicine slide, that might have some potential. So for instance, increasing plant-based protein, reducing red meat, possibly in taking a probiotic. But my response to the patient is, if you want to do that, fine. Like if you want to avoid processed sugar, if you want to avoid gluten, which is a popular thing, that's fine. I can't promise it's going to do any good, but I don't think it's going to do any harm.
Excellent. The next question is there ever a time when patients can come off medications, especially if they've made huge lifestyle changes in their diet and weight loss? Do you ever trial going off the meds?
Yeah, I tell my patients, because you know the concept of forever for anything, right? Like, I have to be on this medicine forever, like forever. I'm like, well, like, you pay your mortgage forever, It's like, we do a lot of things forever. You breathe forever, I tell patients, sometimes more as a reassuring statement, I say, look, I am confident that I can get you on this drug and we're going to clear your psoriasis. If at any point, for any reason, you have concerns or questions that you want to stop it, let's talk about it. I'm always open for patients to stop the drug with me knowing about it. It's these on, off, they missed a dose, now they want to go back on, et cetera. Because with these biologic medications, right, medications made from living cells, sometimes we get worried about autoimmunity, our body getting smart to what we're trying to do with these cytokine blockers. Less and less with the humanized ones, and that's a totally different conversation, but we really like to try to eliminate unnecessary on and off to try to decrease the risk of autoimmunity.
One thing I would say is phototherapy is totally fine to start and stop. So a lot of times we'll treat patients in the winter. January, February are the worst months for inflammatory skin disease. So sometimes patients will start doing it in the winter, do it for a few months, and then come off of it and get natural sunlight. So that's fine. Methotrexate, no antibody formation. So you can do on and off with methotrexate. But we don't have a cure for psoriasis. So just making sure your patients know that, if they are 100% clear and then they stop their medicine, we expect their disease to come back. And most of the trials have a programmed in drug holiday, and usually it takes about 5 months for their disease to come back.
Excellent. And the final question, a two-parter. In this particular person has experienced kickback from insurance companies for prescribing biologics, citing patients need to be seen by rheumatology or dermatology before doing so. So that's part one. Part two is, how do you address the delays that often occur when a patient needs to get to rheumatology or dermatology in these prescriptions?
The elephant in the room.
So I'll take the first part. So I have a couple of colleagues in my network that they will send me a photograph and I'll take a quick look, or they'll even on their secure little video, I'll take a quick peek at them and I say, yeah, I definitely think it's a go. And what they say is, I've prescribed this in consultation with a dermatology clinician, and I've seen that work in about 2/3 the time. I have consulted with the community dermatologist, et cetera, due to 6-month wait time, throw it on them, 6-month wait time. I've consulted in conjunction with, so if you can link up and network with somebody, a fellow APP that can maybe do that, I've seen that work quite a bit.
I agree. I think telemedicine is a great option. I have more availability for telemedicine appointments. I have a few every week. Do you have any? I have like 4 a week, and I find that it's easier to get into those versus like a year for getting a regular in-person appointment. So, telling your patient that there might be an option for telemedicine, we can get a lot done that way. What was the second part, Josh?
And I think it's networking.
Yeah,
it's, how do you go around these log jams of getting in? And it's attending things like this. If you're in the area, I'm happy to give you my email. I say, hey, I got somebody that I need to be seen. I'm worried something is going on. And unfortunately, it is just networking. And I do that with a rheumatologist. She does hair loss. And we go back and forth for about 40 minutes from each other. It's really just establishing those connections in the community to really try to get your patients seen as soon as possible. And I'll always do my best. So
I know.
Wonderful. Tori, Eileen, thank you so much.
Thank you.